Hello viewers, this is Dr. Rajiv. Welcome to your education channel YouTube Surgery and Orthopedic Education. Please consider subscribing it as well as share it to your near and dears to help them in their preparation of MBBS course as well as other postgraduate and job entrance examinations. Also, please don't forget to press the bell icon below so that you never miss an update from us. In the last talk, we discussed breast anatomy relevant to the surgeons undertaking oncoplastic, aesthetic or reconstructive breast surgery. In this talk, we shall discuss diagnostic methodology that typically involves a combination of clinical examination, imaging tests and biopsies, together known as triple assessment. Diagnosing breast diseases involves a combination of number 1. Clinical breast examination including history and physical examination. Number 2. Various imaging techniques. And number 3. Biopsy procedures. Assessing breast symptoms by a combination of clinical examination, imaging and biopsy is known as triple assessment. The application of this methodology is individualized for each patient, depending on their presenting symptoms, clinical findings, and age. An accurate patient history is important for detecting breast diseases. Also obtain a reproductive history including age at menarche, age at menopause, and history of pregnancies including age at first full-term pregnancy. If the patient has had a hysterectomy, determine whether the ovaries were removed. Ask for use of hormone replacement therapy or use of hormones for contraception. The family history should include any known genetic abnormalities and any history of cancer of the breast and ovaries. In history, also target a specific breast complaints. Ask the patient about history of a mass, breast pain, nipple discharge or any skin changes. If a mass is present, ask the patient how long it has been present and whether it has grown or it changes size with the menstrual cycle. If a cancer is suspected, inquire about constitutional symptoms, bone pain, weight loss, and respiratory symptoms. These can suggest relevant investigations and could reveal possibility of metastatic disease. The physical examination begins with the patient in the sitting position. Visual inspection of the breast aims at searching for obvious masses, asymmetries, and skin changes. The nipples are examined for the presence of retraction, inversion, or excoriation of the skin and both sides compared. The use of indirect lightning unmasks subtle dimpling of the skin or nipple that may be caused by a carcinoma. The asymmetry and dimpling may be accentuated by raising the arms high above the head or tensing the pectoralis muscles. The dimpling of skin and nipple retraction are sensitive and specific signs of underlying cancer. Edema of the skin caused by obstruction of dermal lymphatic channels by emboli of carcinoma cells produces PUD orange sign where the skin appears thickened and dimpled, resembling the texture of an orange peel. PUD orange together with tenderness, warmth and swelling of the breast are the hallmark of inflammatory carcinoma. Occasionally, the obstruction of lymphatics by a bulky tumor results in arm edema. Direct involvement of the nipple areola complex by a subareolar primary carcinoma may result in retraction of the nipple. Flattening or inversion of the nipple can be caused by certain benign conditions such as subareolar duct ectasia. These cases are frequently bilateral and the condition has been present for many years. Unilateral retraction or a recent retraction that develops over weeks or months is suggestive of a carcinoma. Neglected central tumors that go undetected for a long time may directly invade and ulcerate the skin of the areola or nipple. Peripheral tumors distort the normal symmetry of the nipples by traction on Cooper ligaments. In Paget's disease of the nipple, malignant ductal cells invade the epidermis and appears as a psoriatic rash that begins on the nipple and spreads off onto the areola and into the skin of the breast. Paget's disease of the nipple is commonly associated with an underlying intraductal carcinoma just under the nipple. The inspection should be followed by palpation of the regional lymph nodes and breast tissue. The breast is examined with palpation of each quadrant and the tissue under the nipple areola complex. The size, shape, consistency, and location of any mass present are noted, and also whether they are fixed to the skin or underlying muscle. Benign tumors such as fibroadenomas are firm, distinct, well circumscribed, and movable. Carcinoma is typically firm but less discrete, and moving a carcinoma drags the adjacent breast tissue. The primary imaging modality for screening asymptomatic women is mammography. In mammography, the breast is placed in direct contact with ultra-sensitive film and exposed by low-voltage, high-amperage X-rays. The radiation dose is approximately zero point 0.1 centigrade, and therefore mammography is a very safe investigation. Sensitivity of mammography increases with age as the breast becomes less dense. Mammography in women younger than 30 years whose breast tissue is dense may not detect any suspicious lesion. As age advances, the breast tissue involutes and is replaced by fatty tissue. The fat absorbs relatively little radiation and provides a contrasting background on mammograms that allows detection of small lesions. 5% of breast cancers may be missed in mammographic screening programs. Hence, a normal mammogram does not exclude the presence of a carcinoma. The sensitivity of mammography is breast density dependent. About 10% to 15% of clinically evident breast cancers have no visible abnormality on mammography. A screening mammography is used for women who have no symptoms of breast disease. Its goal is to detect cancer early when it is most treatable. The American Cancer Society recommends annual screening mammography for women older than 40 years. Diagnostic mammography is used when there are symptoms such as a lump, pain, or nipple discharge, or some suspicious abnormality is found during a screening mammography. Tomomammography, also known as tomosynthesis, and 3D mammography is an advanced tool that creates three-dimensional images of the breast. It is a more sensitive diagnostic modality than mammography. It directly addresses the current limitations of a standard 2D mammography. It uses low-dose X-rays and computer reconstructions. This technique improves the detection of early breast cancers, especially in dense breast tissue, and reduces the need for follow-up imaging. It increases the breast cancer detection rates by approximately 25% and decreases the number of false positive follow-ups by approximately 15%. Recent studies tell that women who have dense breasts could benefit from a mammogram plus fast breast MRI. This combination may result in fewer false positives than mammography and ultrasound alone. An ultrasound is useful in young women who have dense breasts, in whom mammograms are difficult to interpret. The ultrasound is most helpful in distinguishing cystic from solid lesions. A breast ultrasound cannot spot microcalcifications in the breast. Although calcifications are not always a sure sign of breast cancer, yet many early breast cancers are detected because calcifications are seen. Ultrasound can localize impalpable suspicious areas of breast pathology. The ultrasound of the axilla can guide percutaneous biopsy of any suspicious lymph nodes, but it is not useful for screening because it is an operator-dependent tool. Physicians are increasingly using MRI for the evaluation of breast symptoms. MRI is the best imaging method for the breasts of women with implants. It may detect the primary tumor in the breast in patients who have axillary lymph node metastasis, but no mammographic evidence of a primary breast tumor. It may also identify primary tumor in patients with Paget disease of the nipple. MRI is also useful in several other situations, such as for assessing the extent of the primary tumor, particularly in young women with dense breasts, for assessing the extent of residual disease after lumpectomy with positive margins, for evaluating the presence of multifocality and multicentricity in lobular cancer, for a screening of contralateral breast, for evaluating invasive lobular cancers, for assessment of treatment response after neoadjuvant chemotherapy. MRI can distinguish a scar from recurrence in women with previous breast conservation therapy for cancer, but it is less accurate within 9 months of radiotherapy because of abnormal enhancement due to edema. It may assess the extent of high-grade ductal carcinoma in situ, but it is less useful in low-grade ductal carcinoma in situ. It may also assess implant rupture or assess the breast when silicone injections have been used. The sensitivity of MRI is greater than 90% for the detection of invasive cancer and 60% or less for the detection of ductal carcinoma in situ. For routine screening purpose, the American Cancer Society has recommended annual MRI screening beginning at the age of 30 years for women at a high lifetime risk for breast cancer development. A screening MRI should be used after a screening mammography because although MRI is more sensitive than mammography, it may still miss some cancers that a mammogram would detect. The least invasive technique of obtaining a cellular diagnosis is fine needle aspiration cytology or FNAC. Fine needle aspiration can be done with a 22 gauge needle. It is rapid and very accurate if the cytologist is experienced. However, an invasive cancer cannot be distinguished from in situ disease. In a fine needle aspiration sample taken from solid masses, the cytological examination does not differentiate non-invasive lesions from invasive lesions, even if malignant cells are identified. In these cases, a core needle biopsy is needed for definitive histologic diagnosis before surgical intervention. Core needle biopsy is the method of choice to obtain cell sample from breast lesions. Under local anesthesia, using a spring-loaded vacuum-assisted device, cytology sample is obtained using a 21 gauge or 23 gauge needle and a 10 ml syringe. Core needle biopsy can be performed under mammographic, ultrasound or MRI guidance. A core biopsy examination gives a definitive preoperative diagnosis, differentiates between ductal carcinoma in situ and invasive disease, and also allows the tumor to be stained for receptor status before starting neoadjuvant therapy. If a malignancy is detected in the sample, histologic subtype, grade, and receptor status should be determined. As stated above, the core needle biopsy is the preferred method for diagnosis of breast lesions. Excisional biopsy increases costs. It results in delays in definitive surgery. It has been found that results of core needle biopsy is inconclusive in only less than 10% of patients. Only these patients require excisional biopsy for definitive diagnosis. Non-palpable mammographic abnormalities are mammographic abnormalities that are not detectable by physical examination, such as palpation. Common types of non-palpable abnormalities are clusters of microcalcifications, masses, architectural distortions, and asymmetries. Clusters of microcalcifications are tiny deposits of calcium in the breast tissue. They can be benign or indicate the presence of a cancer. Fine, irregular, and linear calcifications that cluster together suggest the diagnosis of ductal carcinoma in situ. The dense stellate masses with speculated borders and distortion of surrounding breast architecture suggest a malignancy. To categorize the degree of suspicion of malignancy for a mammographic abnormality, the breast imaging, reporting, and data system BI-RADS is used. Probably benign lesions are designated BI-RADS 3 and suspicious abnormality as BI-RADS 4.